size does not fit all. How to address patients with obesity from the waiting room to the exam room and beyond. I have no financial disclosures, and all of the images, almost all of the images that I used in this talk are from the Rudd Gallery, which is a gallery of photographs of patients with obesity doing normal health promoting things or just kind of ordinary things, and they are all used with the images are all used with the patient's permission, and are specifically supposed to be used for educational talks and things like that. So while I have no disclosures, I did want to start by just saying that my interest in this topic mostly came from clinical experiences. We now do need to do a lot of counseling about specifically obesity, and in my field, maternal fetal medicine, we have to talk specifically about obesity during pregnancy. And so sometimes we do have to just kind of sit down and talk about it with patients for an entire hour. And when I first started doing this, I did feel very strongly that I needed to use the term obesity because I would never talk to someone who has diabetes without using the word diabetes. I know patients themselves may refer to it as having the sugar or various other terms, but I felt it was clinically important to use the medically accurate word. And then I got some patient feedback that made me think maybe I need to approach this. Perhaps the word obesity could be on some printed materials that we provide, but not use it quite so much, in actual conversation. And so that sort of was what stemmed my interest in this talk. But I have done research on obesity for about almost 10 years now, as a resident and as a fellow. So I just had never encountered the literature about sort of how to talk to patients about obesity when they have it. And so that is what stemmed my interest in this. The goal of today's talk is intended to address some of the concerns and discomfort that many of us expressed on the provider survey about discussing obesity with our patients. And the goal of today's Grand Rounds is to increase our comfort in discussing obesity with our patients by providing some tools about not only how to broach the subject, but also to provide some resources that we can provide to patients to support them in their journey towards a healthy weight. And I'm also happy to share all of these slides. I've sent shareable slides, and so you're welcome to reach out, and I will send those to you, or you can also reach out to Jessica. The learning objectives are that at the end of this talk, the learner will be able to grasp the scope of the obesity epidemic and its impact on the obstetric and gynecologic population, appreciate the stigma associated with being obese and the challenges patients with obesity face, just not only in their day-to-day life, but also specifically when they're visiting healthcare providers. Then finally, I want to discuss some of the barriers that we as providers perceive when discussing obesity with our patients, and understand how to create a welcoming environment for patients with obesity when they come into our waiting room, when they come into our offices, and also how we can use the appropriate vocabulary to discuss obesity, master some tools to guide this discussion, such as the 5 A's, and also I'll briefly touch on motivational interviewing, but I know that'll be covered in more detail next month at a separate event. And finally, go through some resources that are available. So first I'm going to talk a little bit about the scope. So over the last 30 to 35 years, the prevalence of obesity in this country has risen dramatically, as you can see in these pictures. When we first started collecting this data, many states actually had under 10% rates of obesity, and in 2013 they actually had to completely rechange their color coding because any given state had less than 20% rate of obesity. And these data, by the way, are all self-reported, and so the rates actually may be even higher than what's portrayed here. This is based on data from telephone surveys. Not only has the prevalence of obesity increased, but also the actual severity of patients' obesity has increased as well. It's not like in that graph, everyone who is walking around has a body mass index of 31 or 32. The percentage of patients who have a body mass index over, this is really weak, over 50 has also risen about 120%, just in the 10 years shown on that slide. And this data shown here is also almost 10 years old now, and so obviously continuing to rise. Here in Wisconsin, just a few weeks ago, the Wisconsin Health Atlas published the rates of obesity by zip code on the map of Wisconsin. I show here women of reproductive age. On the left side of the screen in the blue is the obesity rates for females aged 18 to 34 by zip code in the range of Rates of obesity is from 9% up to 59%, and that's in women who are between 18 and 34. Also in the reproductive age groups are women 35 to 54, and that range increases up to 71% in some counties. There are also several zip codes that don't report data, and so it could be even higher than that in some areas. Here at Merida, we're no exception. Shown here in blue are the number of patients delivering here, so this is obstetrics data, and in red is the number of C-sections. And 60% of the cesarean deliveries that we do here at Merida are performed in women with body mass index over 30. And in any given year, we have up to 30 cesarean deliveries that we perform in women with body mass index over 50. And just to kind of go through, we do about 500 or so in women with body mass index over 30 in general. And you have seen this data before from various other settings. So the risks that we kind of have to talk about in obstetrics are obesity increases the risks of many of the adverse obstetric outcomes ranging from preeclampsia to diabetes. For preeclampsia, for example, this adjusted odds ratio is very similar to that for women who have pre-pregnancy hypertension. So not quite that high, but is in a similar range. Also increases the risk of preterm birth, PPROM, and after delivery and around the time of delivery increases the risk of infection, particularly for body mass index over 45. In gynecology, in the pediatric gynecology literature, obesity increases the risk of early puberty, decreases contraceptive efficacy, increases the risk of menstrual problems and endometrial hyperplasia. And kind of just across the board, depending on which source I looked at, sometimes they didn't give a very good degree of the risk, but anything from urinary incontinence to decreased fertility, difficulties with ART, increased miscarriage rates, and of course in gyn-onc it increases the risk of endometrial cancer most famously, but also ovarian cancer and postmenopausal breast cancer. So spans kind of across all of the different divisions here in the Department of OBGYN. So I'll briefly touch on the causes of obesity. I think we mostly think about environmental causes of obesity, things like diet and exercise, but there are also significant biological and genetic causes and also psychological causes. As I said, we typically think about diet and physical activity as contributors to obesity, but the environment overall, the world in which we live, has really slowly evolved over the past century to be a very obesogenic environment. With anything from food deserts, patients aren't able to access fresh fruit and vegetables and healthy food options, lack of safe places for people to exercise and to even just walk around. Many cities or areas can be pedestrian or biker unfriendly, which reduces people's ability to get physical activity. Types of employment in general have changed over the last century. Serving sizes has changed. Dietary composition has changed, and also there's a price difference between healthy versus unhealthy food, which can promote eating more unhealthy food. However, things that we don't think about as much are, genetics and physiology. I was surprised to learn that up to 70% of obesity can be attributed to genetic factors, and so there can be very strong genetic input into, a patient's predilection to develop obesity. The other issue is that physiology really opposes weight loss. Intentional weight loss can lead to physiologic adaptations such as changes in the activity of various hormones like ghrelin and leptin as the body attempts to kind of conserve energy stores. And also as patients start to lose weight, their metabolism itself slows down and increases hunger, which makes ongoing weight loss difficult and also makes it hard to maintain the weight. Once a patient reaches their goal, and is willing to start letting up a little bit, they start getting hungrier and hungrier, and it can lead to that yo-yo weight up and down effect. And that's something that has famously been seen in patients who are on a TV show like World's Biggest Loser or things like that, where they are put on extremely restricted calorie diets and then they have a lot of physical activity. When they go back to leading their ordinary life and eating ordinary food, their metabolism has slowed down so much that sometimes they can actually really bounce up to where they were at or higher. And so there are real effects to that as well. Despite this increasing prevalence and increasing degrees, there is some data on patients' perceptions of whether or not they're obese. 22% of women, for example, with obesity correctly classified themselves as obese, and so nearly 80% of women did not recognize that they fell into this category. 50% of people with obesity see themselves as obese. This first data is from 2008, and so this may be improving. This is data from last year. 55% of patients report having received a formal diagnosis of obesity. And so a lot of patients don't ever remember their physician ever mentioning this to them. And 65% of people with obesity agree that obesity is a disease or that it has health consequences. Even among healthcare providers, many of us may misclassify ourselves. I didn't want to go into the rates because they were a little embarrassing, but a lot of healthcare providers failed to recognize that they fell into this category as well. And there are also some ethnic and racial differences in patients' ability to self-report obesity and also recognize associated health risks. So I'll kind of move on now to the stigma associated with being obese and some of the challenges patients with obesity face when they come to see us. Many patients with obesity may have had obesity their whole life, and so they could have decades of experience of having people put them down for being obese. And here are some quotations from a qualitative study. One patient said, "At school I was always picked on for my weight," and another patient in a study mentioned that she was always on some kind of diet. The first one was Jenny Craig, starting when she was 12 years old. And so by the time she came to see a provider, she'd been on a diet, on and off for about 20 years. And so that's sort of part of the experience. In terms of stigma, stigma is defined as a mark of disgrace, and experiencing weight stigma can undermine health by contributing to obesity, metabolic disease, psychological disorders, and ultimately mortality. The Obesity Action Coalition says that obesity stigma is a major issue and is the last socially acceptable form of discrimination in our society. Discrimination in many other forms is unfortunately becoming less acceptable, but this is one that continues to prevail. Bias is prejudice in favor of or against one thing, person, or group compared to another. And weight bias is a bias against those who carry extra weight. It's commonly based on false assumptions about the causes of obesity, and it can be either explicit and intentional, or it can even be implicit and unintentional. Weight bias and stigma can actually significantly affect patients' health. It can impact our clinical approach, and it can actually keep patients from receiving health care. There was a study done that showed that of American adults surveyed online, when they asked what they'd do if they felt stigmatized about their weight from their doctor, a full 19% said that they would just avoid future appointments and just wouldn't go, or 21% who would find a new provider. So that's around 1 in 5 people not even coming back for health care if they went to a doctor and they felt that they were stigmatized in some way or had a bias placed against them. And taken together, this can all lead to increased morbidity and mortality for patients because they have kind of that unfortunate combination of a health condition which could worsen their health and an unwillingness to seek care because they don't feel welcome. Physicians ourselves, we are not immune to weight bias either. This was a study done where physicians were presented with some sample charts with some vitals and some information about the patients, and they were asked to kind of look it over, say what they would talk about how much time they would spend with the patient. And when they were presented with a chart for a patient with average overweight versus obese, versus obesity, the amount of time that providers would spend with the patient decreased rather significantly from about 30 minutes to 22 minutes. They also were more likely to feel that seeing the patient was a waste of their time, and also less likely to think that the patient had self-discipline or follow their advice. Then this was from a different study where physicians were asked to kind of rate characteristics of patients with obesity on a scale of bad terms like awkward to positive terms, with kind of the higher term being the more negative term. Physicians were more likely to rate patients with obesity as being awkward, lazy, negative terms, although they did rate such patients as being more pleasant and honest. I thought I would also present you guys with an opportunity to check your own implicit bias. I have here a link to the implicit bias test, or you can Google the term implicit bias test, and it's the first link. And one of the options, there are many options on there, but one of the options is you can check your bias about patients' weight. And essentially what this test is it will kind of go through, it says, we'll give you a list of good terms, a list of bad terms, and we'll show you the silhouettes of patients with obesity and the silhouettes of people without obesity. And then what you're asked to do is essentially you are asked to categorize either the silhouette into one of the two groups or the term into either good word or bad word. And then they kind of group the words differently. Either they group bad words with they use the term fat people, or good words within people, or then they switch it around. And so based on the amount of time it takes you to answer each of these questions and your accuracy, it will tell you sort of your degree of implicit bias. And it's just interesting. It takes about 10 minutes, but sometimes you can learn a little bit something about yourself. And here are some of the other terms that are on there. And so they kind of intermix words and also the silhouettes. So just something you might consider trying. There was a study where they did this test on physicians, and physicians, as I said, are not immune. We're more likely to rate the attitude of patients with obesity as bad, and kind of also fit into the stereotype of lazy or less motivated. And so that's something, if you guys want to learn a little bit about yourselves, that can be a nice link to do. Another important step is to use people-first language. Instead of saying someone is an obese person, and you'll still see that in the literature, but try to just kind of remove that word from your lexicon, talk about it a little less, avoid labels because labels lead to bias and discrimination, and what's preferred now is to use the term person with obesity. So use the word person and then the term, similar to person with diabetes as opposed to diabetic. Next, we're going to talk a little bit about the barriers that we face when we're discussing obesity with our patients. So what are some of the barriers? So big ones include time, perceived efficacy, and lack of training, and I'll go through these in a moment. This is data from us, from our department. Do we think there's enough time to address obesity during a standard visit? And the majority of us thought either rarely or maybe sometimes, with very few thinking that we always have time to do that. And that's similar to what we see in the literature. 52% of providers in the literature, talk about how there wasn't enough time and/or there was some more pressing diagnosis that needed to be discussed. During a standard visit, how much time do we spend discussing obesity? The majority of us essentially spend less than 3 minutes when we talk about it at all, with several of us never really talking about it. Other barriers are lack of perceived efficacy. There seems to be kind of a bimodal distribution here, showing that a lot of us are not completely confident that they can change, and those of us who do think it, sort of think it, but not super strongly. And that's also, that differs a little bit from what's seen in the literature. This graph is from a paper talking about physicians versus patients with obesity's perceptions about ability to change. And here physicians are shown in the gray, and generally we're actually a little more optimistic than patients themselves. Last barrier is kind of the lack of training. We're not sure how to bring it up, not sure what language to use, and we feel a little embarrassed. This graph talks about, the top part talks about reasons that patients with obesity don't seek healthcare help for seeking weight loss, and this is the healthcare providers' reasons for not bringing it up. And for patients with obesity, the main reason that they don't bring it up is they feel like weight loss is their responsibility, and they don't feel like saddling their provider with that. Not so much that they're embarrassed, but they are sometimes. For providers, the overwhelming response is that they feel embarrassed to bring it up with their patients. The other reason is that we don't necessarily feel that we're very successful, with kind of most of us feeling either bad or really bad about how successful we are with that. The next big barrier, and what I'm trying to address today, is the amount of training that we've received on talking about obesity. Most of us have last received this training while in medical school, and a full quarter have received no training at all. And so today's session is hoping to address some of that. So can we do it? What do you think? And yes, we can. So here we go. All right, everyone, roll up your sleeves, because here's some tools for how to talk to patients about obesity. So again, I'm going to go through kind of how to create a welcoming environment for patients with obesity, how to use the appropriate vocabulary, and a couple of other tools for the toolbox. So Regarding time, the interventions that I'm going to talk about are relatively short. The actual amount of time expenditure used is being investigated, so there will be papers coming out on whether 5 minutes is sufficient, 3 minutes is sufficient, all that stuff. That data isn't out there, but I've found some studies saying they're doing that. Is there a minimum amount of time? I still don't know, but probably something is better than nothing, and that's hopefully what these studies will show, that they're still out there. However, there is data that counseling is associated with motivation to lose weight in patients and also intent to change behavior. And we say we don't have much training, but there have been studies showing that even 90 minutes of training increase the percent of patients who physicians who counsel patients about obesity, and counseling patients about obesity can actually increase the quality of the patient-physician relationship. And the tools are on the next slide. So today is 60 minutes, and if you're able to attend one of the future sessions, that'll actually be like 2 more hours, so we're going to be exceeding the 90 minutes. So hopefully this will at least get us a starting point. Solutions for the time barrier. When you're using motivational interviewing and brief encounters, 4% of studies showed an effect. And the brief encounter is a total encounter lasting of 15 minutes. And it doesn't talk about in there how much of that 15 minutes was talking about obesity, but that is kind of the standard appointment. When you come in, you talk about, the AUB and the fibroids or whatever, and then you can also talk about obesity if it's related. Then kind of perceived efficacy. As I said, despite our lack of confidence that counseling patients about their weight will have an impact, there is evidence that it's associated with behavioral change. So kind of next I'll go on to the environment and the preferred vocabulary. So for patients with obesity to feel welcome, we need to start optimizing the whole clinical environment, starting at the front door of the clinic and the waiting room. Is the environment safe? Is it accessible? Is it accommodating? Is it comfortable? Is it non-shaming? Is it welcoming? For example, imagine that a patient with obesity walks into this waiting room. Do they have a place to sit? Do they feel non-stigmatized? All of these chairs here are, relatively narrow, and they have armrests, which would also restrict the ability of patients with obesity to sit down comfortably, and not potentially either injure themselves or even fit in the chair physically. And so, so there's a move where if you'd like, if you want to make patients feel more welcoming, you would have potentially other seating options, and ideally more than one of these. And so these are pictures from the Center for Perinatal Care, and we have at least 3 chairs like that in addition to chairs in our, and we also have benches that don't have arms whatsoever, elsewhere in our clinic. Also seating for people of other sizes too. And so, and this is another waiting room picture that I found where, it's just a bench altogether. There are arms, if patients need help getting up, so there are armrests available to help with that, but in general, there's no restriction on the size of patients that can sit on these chairs. At intake, sometimes some clinics have the person who's doing intake talk about the reason for their visit, right at intake, which can be stigmatizing, especially because sometimes it's loud or not terribly private. And there's really no need to, talk about why you're there when you're checking in. At most you should just have to say your name and not that you're there to talk about obesity or anything like that. Other things are in the hallway. Many clinics can have the scale in the hallway. The patient steps on it. The nurse says the weight out loud and writes it down in the chart. And other patients and staff are walking by, and that can be rather stigmatizing. So there's no reason that the scale can't either be in an alcove or a clinic room or somewhere somewhat private. Write down the number, and then you discuss the exact number of the weight issue in the room itself. In the exam room, it can be helpful to have extra large patient gowns and not have to be scrambling around trying to find these. Sturdy armless chairs, split toilet seats that are not mounted on the wall, because the ones that are mounted on the wall can actually break off. In bathroom specimen collection cups with handles, that's particularly important for clinics that do a lot of urine studies. Step up and wide examination tables, scales that can hold a certain capacity, and reading material that's focused on health behaviors rather than thinness. And in OBGYN, especially, we benefit from having larger long-titled specula, and ideally in every room, so that when it's time to examine someone, you're not running around the hallway, where is that speculum? Just have some in every room so that you're not scrambling around and making the patient feel awkward. And also having large blood pressure cuffs or thigh cuffs. Now in terms of preferred vocabulary, patients have been asked to rank different terms: weight, BMI, weight problem, excess weight, overweight, obesity, excess fat, and fatness. And when asked kind of on a scale of very undesirable to desirable, terms that patients tend to prefer are terms like just weight, or body mass index is seen as rather non-stigmatizing, BMI. Some patients also prefer the term unhealthy weight or unhealthy BMI with the goal that they would be getting to a healthy weight, in the future. Terms that are obviously disliked are fatness or excess weight. Across the board, different studies, women in particular, they also like weight, excess weight, BMI. There are many studies on this that show similar trends. With some not liking terms like heaviness, large size. However, extremely obese women also don't particularly like the term excess weight, heaviness, large size. And they uniquely don't like the term unhealthy body weight or unhealthy BMI, because a couple slides ago, the term unhealthy was thought to be positive. And so it does vary a little bit. You may also consider on your intake questionnaire, if you have one at your clinic, asking patients if they have a term they prefer you use if you're going to be talking about obesity. Most desirable terms are listed here on the left, less desirable terms on the right. So the word obese isn't uniformly disliked. Some studies actually found that some young patients and some actually found it a little motivating to use that term, or they thought that it would be acceptable from a health professional, although not typically acceptable when they're talking to their friends. Some people actually preferred if a physician would use a term like clinically obese, just so that it can be clear, yes, this is what we're talking about, but not using it in the same way that you would socially use the word obese. And so, so different patients differ, but some actually liked the term obese, and so a little bit of a division there. But across the board, kind of the general sum of it seems to be, if using the term obesity, it can be helpful to emphasize that it's a clinical term rather than a description of their physical appearance. So how to rate the topics and kind of go into 5As, and I provide some sample questions. The 5As are adapted from other behavioral change models in obesity. Ask, assess, advise, agree, and assist. First, you want to ask permission to discuss weight, be non-judgmental, and explore readiness for change. Assess their BMI, their weight, advise them on the health risks of obesity, agree on realistic weight loss expectations, and assist them in identifying barriers and kind of arranging follow-up and referrals when necessary. So one of the important steps is to ask, may I talk to you about your weight? Are you concerned about your weight on your health or your quality of life? You want to be sure to kind of affirm what the patient says. It can also be helpful to consider, the patient's weight and whether it's relevant to their actual presenting complaint. You mentioned, for example, sample sentence, you mentioned a number of symptoms, such as this or that, which may be related to excess weight. Would you like to talk about this to see if we can help you feel better? And that can be relevant to topics in gynecology as well. For example, among our providers, we are actually more likely to talk to a patient if it is related about their obesity, if it's related to their comorbidities. So for surgeons or surgical subspecialties like us, it can also be important for us to bring up, and here's a sample sentence, we know weight can affect the safety or success of doing an operation. Has anyone talked to you about this? And follow with, is this something you'd like to discuss further or get support with? And I'll go into this later in resources, but there is actually like a medical weight loss clinic at UW that will help patients lose weight prior to a surgery for not bariatric surgery, but if someone, just for example, has a large hernia and they need to lose 40 pounds before they can get that surgery, they can help them put them on an extremely low-calorie diet to get them there. And that can be relevant for gynecological conditions as well. In the assess, one of the steps is to kind of figure out where patients are in their stages of change. Are they pre-contemplation, are they contemplation? Some patients are here and it's just going to be hard to reach them, but many patients will be somewhere else on the circle and you can help them actually get to another point. There's some suggested ways to kind of assess where they're at in the stages of change by just asking like a couple things. For example, how likely are you to consider a couple of small lifestyle changes, specifically ones that would lead to increasing physical health and eating healthier to improve your health? Or would you be willing to incorporate extra physical activity in your daily routine, such as taking the stairs? While having this conversation about, increasing activity, there's also language that's liked and not liked about this. Patients don't want you to talk about diet and exercise. Language that's preferred are terms like eating habits and physical activity. Talk about physical activity more than actually going out and exercising. But what if you have to talk about it? And I couldn't really find much literature on this. In obstetrics or maternal fetal medicine, sometimes patients are referred to talk about obesity in their pregnancy. And so we, of course, run the risk of saying, would you like to talk about your weight today? And the patient says no. That's kind of what they're there to talk about for the next 30 minutes. So should we ask, is that appropriate? I couldn't really find much on what to do about that. My approach is typically, I ask if they understand what they were referred for, and then I sometimes just say, and one of the things we need to talk about today is, excess weight, and just kind of go through it. Because, otherwise you do run the risk that they're perhaps in a pre-contemplation stage and then you can't talk about it, and it kind of misses the whole point of the referral. So I don't know if that's right. I couldn't find anything about it, but it seems to, at least since I've tried that approach, it seems to have been well received. So, of course, when doing that, you still use the same language, as non-judgmental as possible. And something that I found sometimes helps is having kind of a worksheet or something that I'm kind of talking through with, about their condition and kind of some of the possible effects on the baby and their pregnancy, and just kind of going through that without staring at them the whole time, because then I feel like that body language implies that is stuff that could happen to them, or that I'm lecturing them in some fashion. And sometimes just going through things together and allowing them to take notes, talk about how much weight they can gain, things like that, seems to be better received. But again, I'm not saying that that's the end-all answer. This is something that I'd like to research in the future. In terms of advice, this is advising about the risks of obesity, explaining the benefits of modest weight loss and the need for long-term strategies. So now that we have a better understanding of your situation, can we explore and come up with a plan of action? So I have here a sample scenario, and I apologize if I have some gynecological facts mixed up or anything, but I did a GYN patient because I wanted to reach across the aisle a little. Regina is at the office today to discuss surgery for, I had it on there initially transoperatory tape placement, but then I wasn't sure if that was still done, but due to stress, urinary incontinence, her BMI is 45. You're aware that there's evidence that weight loss in women with obesity can actually improve urinary incontinence, and there's a higher risk of operative complications in women with obesity. So what should you say? So here's some sample sentences of things you can say. Regina, the charts indicate that your body mass index is 45. Would it be okay if we discussed how your weight may affect these symptoms? And so the agree step is kind of about respectful negotiation to achieve the best weight focused on some specific, measurable, achievable, rewarding, and timely goals. And any treatment plan should use effective behavior modification, such as, for example, motivational interviewing. Motivational interviewing is one approach to patient-centered communication that explores and attempts to kind of resolve patients' ambivalence about behavior change. And a meta-analysis has shown that it can actually reduce weight. What it is it's kind of a collaborative conversation that strengthens a person's own motivation and commitment to change. So if they're pre-contemplative, you may not even get to this. It's not to try to strong-arm patients into doing what you think is best for their health. It's not about trying to talk them into it. So essentially, the goal is to discover and activate the patient's own motivations, kind of provide support and resources, with the goal of improving health and quality of life. So you want to find some points that the patient is willing to change, go for small, incremental changes with goals that are specific and measurable, achievable, relevant, and timely. So, for example, you go back to Regina, and she would like to try to lose weight to see if it improves her stress and incontinence. So you say something like, what changes are you willing to make to achieve this goal? To just losing a little weight. And she wants to start small, and that's okay. You just work with her. She says, I'd like to work on serving size and understanding food labels. Do you have anything that can help me with this? And so we'll go through the tools for that later, but I wanted to say that motivational interviewing will be discussed further for members of the UW faculty, the residents and fellows at the upcoming faculty development workshop. on September 20th. So this will be covered in full 2 hours in more detail. So this was just kind of a couple of teaser slides about that. But if you're eligible to come to that, come to that. September 20th at the Fluno Center. So next to the resources about the food labels. So when we interviewed ourselves, us faculty, about what resources we'd like to use to communicate with patients about obesity, number 1 was websites, number 2 was mobile apps, and number 3 was patient handouts. So I'm going to kind of go through some of those resources. And looking at what family medicine providers use, the top 3 are actual, EMR embedded resources like that AVS stuff that prints out on the after visit summary. USDA MyPlate resources, and that's a website and also an app, and smartphone apps such as MyFitnessPal or Lose It. So here's a list of some good websites. MyPlate.gov and the FDA has some good information about how to understand food labels, and these can be helpful. CDC has some nice resources about portion sizes. And looking at how well these work in various other weight loss programs, there was a study looking at postpartum women using an internet-based weight loss program, and women who used the program lost 2.3 kilograms more over the 12 months postpartum than women who did not use the app. Both groups lost weight because they were postpartum, but it was like a full 5, about 5 pounds difference. So, in terms of apps, there are way more out there. If you go on your app store, you'll probably find like thousands. I took these from kind of various websites that rated kind of the top 5 to 10, and so anyone who has an iPhone has Apple Health usually preloaded on there. MyFitnessPal allows you to take photos of food labels, and it will put it into a calorie tracker. It also will link with your Fitbit. There's special coaches for women, and then there's one that will even take the miles that you run and walk and donate a certain percentage of money to the charity of your choice. And where that money comes from, I don't know. But all of the apps shown here are free. So these are all free resources for anyone who has a smartphone. How effective are these mobile apps? There was an RCT using PDAs, and telephone coaching, and there have been research showing that kind of using the intervention, patients lost, about 3.9 kilograms more. There was meta-analysis of these apps and showed that overall it's promising. They didn't give like a really good range of different weight losses, amount of weight loss, but they think that that the interventions using mobile phones were actually better than the ones using PDAs, but maybe helpful. And in obstetrics, there was a postpartum weight loss study that saw that patients who used an app lost 3.2 kilograms more than usual care, and that was at 14 weeks postpartum. There are also studies done using telehealth and eHealth. And there was a meta-analysis of 10 studies in the obstetric population looking at postpartum weight loss at 3 to 12 months, and patients in the intervention arm did lose more weight. So, can be helpful. If you work with a population that doesn't use smartphones as much, there are also low-tech solutions, such as daily self-weighing. All you need is a scale, which ranges in cost anywhere from like $5 up to like $20. And in the general population, not specifically obstetrics or gynecology, but daily self-weighing can help patients lose more weight or just be more aware and have less calorie consumption. Here was a meta-analysis that showed the rates at which patients shown in gray with obesity, lost over the course of a year, were more likely to lose about 4.5 kilograms than those who weigh themselves only weekly or monthly. And so even just being aware of your weight can be helpful. I show here some resources and programs. This first, the weight management program can help with the medical weight loss with extremely low calorie diets if they're needed prior to a surgery. For an indication, that's the one that I talked about with the hernia repair. If the patient needs to lose 40 pounds to be eligible, can be helpful. There may be some gynecologic applications for that. There's also a weight management clinic. And the family medicine has kind of a program that's integrated approach with many components to it, healthy living activity guides and also some complementary medicine. And there's of course surgical weight management available here as well. There's a bunch of handouts that that we have on the UConnect website that are available. And here, as I mentioned, we're having that motivational interviewing seminar. If you can't make it to that, there's also an online training given by the same instructor. Obviously, in person is better, but if you're not able to attend that for one reason or another, this other course is available on UConnect. What's cool here at UW also is there's a whole UW Health Pediatric Fitness Clinic where kids with obesity can go to what's essentially a gym, learn how to do various activities, with kind of a coach who can help them gain confidence, and they feel less self-confident in their gym clothes than they may feel going other places. There's a bunch of links here for patient information, and as I said, I'm happy to send you these slides. There's professional information. The AACE slide library is really awesome because it actually has, it's laid out similar to the California collaborative for obstetrics, where it has toolkits and education for nurses and clinics, and where you can even buy the equipment. The larger blood pressure cuffs and larger chairs and things like that. And so it's kind of an all-encompassing website. And then some future directions are in medical education. Dr. Shada of General Surgery is creating an obesity elective for medical students comprised of internal medicine, family medicine, general surgery, pediatrics, and obstetrics and gynecology. And other programs such as Medical College of Wisconsin has a collaborative curriculum on obesity as well. So future places may have that as well. In obstetrics, we're looking to see if maybe there are some prior research showing that focus groups like the idea of group prenatal care for obesity, and so that may be something that we are heading towards in the future. But of course, prior to building that, we're kind of working on the steps to seek patients' perspectives to inform the development of such programs. So kind of going back to Regina, after reviewing resources on food labels, she sets the goal that she'll look at food labels on everything she eats and record the calories either by hand or on an app. And she'll do this for 2 weeks and see if there are any areas where she thinks she can make changes. And I'm now open to questions. So I went through a lot of things, but I did want to leave about 10 minutes for questions. So. And I think Kara had to step away because she's on service. I don't know if someone wants to referee the questions. Cynthia?
I don't know if I need my phone, but I remember doing this. No, I think you might be
This is, I think, being recorded, so for our home audience, I'll try to be articulate.
So I remember doing a lit search for one of the WAPC great debates about this topic of language usage, and I was assigned to the side of the debate that said you're supposed to use the word obesity with the patients. And the data that I had looked at to sort of specifically defend that side, because I was assigned to defend it, is that there's pretty good evidence to show that if you use the word obesity, you do get lower patient satisfaction, so patients don't necessarily like it, but they're more motivated and they actually achieve more lifestyle change in terms of decreased caloric intake, more exercise, and better weight loss. Yeah. I'm wondering what your thoughts are in that balance between trying to get people to actually change versus our patient satisfaction scores.
Right, and I couldn't see some good literature on that. One tool that I sometimes do is I get out the actual BMI and obesity charts, and so, and I just kind of show this is where you are, and that sort of thing, and it has the word obesity all over it. And so I think they're seeing that, but it's not me saying it. Or having handouts that use the word, I think would probably be acceptable. I think what is troubling the patients is us using the word and them perceiving it in a social manner. That slide that I had where I said some patients seem to prefer if we use the term clinically obese. And so we're saying this is not about how you look, this is not about how society sees you, but on our screen we are seeing that the numbers are this, which leads to the definition of clinical obesity. Trying to make it as destigmatizing as possible. But I didn't really see much about the balance, like you want to motivate, but you also don't want to alienate, and how to best kind of achieve that. Deb, do you have an input?
Yeah, well, so first of all, it's a really hard topic because, I think we're all pretty uncomfortable and patients are pretty uncomfortable. Thanks. And, so I'm kind of thinking back to my experience, and I think you guys are in a really unique position regarding obesity. One thing that, certainly in thinking about behavior change, when you guys learn about motivational interviewing, this will all kind of really come together. But, what helps is not to be, is not to shame people, is not to stereotype them, all of the great stuff you talked about. But, certainly around comorbidities, that's a place where you guys can come together, Your symptoms will get better with some weight loss. We're not treating your obesity, we're not trying to put you into a normal weight range. We're trying to help you feel better, be able, and so like when I have patients who have hypertension or glucose intolerance or diabetes, for them understanding that that a little bit of weight loss will decrease their reliance on medication, will make their sugar control get better, that kind of hooking to their goals rather than this number can, I think, be motivating. And I think you guys are working, people want their birth outcome, to be a positive. And people want their incontinence symptoms to get better. And people want to, in the world of medicine, people want to go and get that knee replacement. So kind of, rather than focusing on the number, really kind of focusing on those goals, I think.
Right. And, the goals can be small as well. I kind of went into that, sometimes it's just, maybe if you lose X%, then your cycles will be more regular, or
You'll
some.
So one of the things, I was fortunate enough when I was in Chicago, I had 2 master's dietitian students from the University of New York working with me as part of their project. And one of the things I found out, first of all, was that we're really underprepared for the reality of talking to people about nutrition and physical activity. Most people don't want to be obese. Any one time in my half-day clinic, we found about 72%, I think, of my patients, or 70% were classified as obese. And one of the things that it's nice to do the motivational, like you're doing, the question is, what can we do in the future to take 2 hours and bring experts on both the nutritional, the medical, and the surgical to teach us how to counsel these patients. Can we incorporate, as part of the residency program, a day or 2 in a bariatric or a nutritional program where residents can learn more about it? And also, can we as physicians and attending physicians, they do have bariatric, programs, obesity medicine, things that we can do as part of CME that are conferences and things like that. But this is crucial because the number one reason people die is heart disease, and a lot of that's going to be related to comorbidities that stem from obesity. So I think we have a really unique opportunity as OBGYNs to impact the long-term health of women. But a lot of us are unprepared to undertake some of those conversations, even primary care doctors, let me be quite honest with you, no disrespect. But, they don't want to touch these subjects sometimes because they're in the same boat we are in terms of preparedness for nutrition and things like that. Because the medical schools sometimes don't cover it, residencies aren't covering it significantly, and we just tell people to go out and lose weight. And everybody wants to be normal.
Thank you so much, Katie, for doing this talk. I have a couple of kind of thoughts. One thing is that at the Healthy Aging Summit earlier this summer, we had sort of this phenomenal keynote speaker who talked about our current healthcare delivery system really being based on the goal of sick care and treating acute illnesses, whereas most of the morbidity facing Americans today is chronic diseases that are mostly related to promoting health rather than doing acute sick care. And so I think we all feel a little bit overwhelmed with tackling promoting health because that's not how medical training is structured. That's not what we're experts in. And so all of these sort of like goals to help patients make healthy choices and sustainable behavior change, there's like an entire literature and training around that, and it's really different than our training. And so I wonder if a better solution for us would be making partnerships with organizations with a mission of promoting health. You know, like a lot of senior centers and aging units offer programs that teach evidence-based behavior changes to help patients manage chronic conditions. And so perhaps instead of us trying to become experts in motivational interviewing and learn what nutritional strategies we should be recommending, perhaps what we need to be thinking about is how we start the initial conversation and do the warm handoff to folks who might be better equipped to tackle this issue. And then I just wanted to share something. I have a Regina in my clinic who I've been taking care of since I came here in 2013, whose BMI when I met her is 55. It's now 45. And she went to the medical and surgical weight management program before I met her and had a very negative experience and was evaluated and deemed not to be a good candidate for bariatric surgery at that time. So I was about to do an InterStim, an operation for urge incontinence, which gets better with weight loss. And I've said to her over the years a number of times, like, you know, how are you feeling about your weight? And it's, you know, and then we talk about it. And finally, she's like willing to reconsider bariatric surgery. And so I placed the referral. I even messaged the doctors. And the response back was like, well, you know, we evaluated her 10 years ago and she really wasn't a good candidate. So it's unlikely that this is going to be a good fit this time around.
Even though she had lost weight and didn't change?
Yeah, so I mean, I think like, so I just think it's a really complicated landscape, and I'm not sure that I'm not sure that our health system even is necessarily equipped, and maybe we should be thinking about maybe we should just be thinking about other partnerships that might help us, because this is like a new frontier in medicine that none of us have been really trained. So I'm taking up too much time.
Laura, can you?
I was just going to say that all of my patients come with their partners. And so I was wondering if you had seen anything about talking about this with other people around. You know, so I will talk to them about weight, but then we'll try and ask them if it's okay if we talk about numbers, because sometimes for IVF, our BMI cutoff is 45, and I like to give people, like, if you lose X number of weight, you get under BMI of 45. But I want to be cognizant of sometimes their partners don't know their weight, and they don't want their partners to know. I don't know if there's anything that you've seen.
I do specifically do a lid search for like counseling patients about obesity with their partners present. I will occasionally actually ask the partner to leave a room just for a few minutes so we can like talk about some things. You know, that just may be a little more personal. But I didn't specifically look for that, so there may be literature out on that, but that's a good point as well, because I can sometimes sense when someone's starting to get awkward about it. Deb, did you have one more thing?
Well, I was just gonna, agree with Heidi. I mean, we're physicians. We're good at healthcare, and this is way more complicated than that. And I think helping us, help patients understand why weight loss will address these medical issues is really important. But we're never going to solve obesity as counseling from a physician.